Good afternoon, my dear students. Now we're starting a new semester, and semester is new and our submodule is old. Today we continue submodule signs and symptoms of respiratory system diseases in discipline Propaedeutics of internal medicine. And our today's topic is syndromes from fluid accumulation in the pleural cavity to respiratory failure. It is a range of syndromes that I want to discuss with you today. All of them are very interesting and very important in pulmonary disorders, pulmonary patients, and therapeutic general practitioners' practice at all. And before we start lecture, I want to remind you the importance of respiratory system. I showed you this slide in previous lectures about respiratory systems. Let's repeat it one more time about importance. All of us remember that food, water and oxygen are basic necessities of life and we can't survive without them. But if the average person can live without food 3-4 weeks, without water 3-5 days, and oxygen is crucial to sustain life, and 3 minutes is maximum time where a person can stay alive without breathing. And for today I have you, as usual, several USMLE tests for yourself, working and individual working with material of lecture. And like an introduction, they discuss first question. A 78-year-old woman with a past medical history of heavy alcohol and tobacco use, esophageal cancer and chronic pancreatitis presents to the emergency room with shortness of breath. Her blood pressure is 165/94, heart rate is 118 beats per minute, respiratory rate 31, saturation 78 on room air. She then undergoes a thoracocentesis for evaluation the left-sided pleural effusion. Which of the following result is consistent with pleural effusion secondary to an esophageal perforation? First, fluid LDH or lactate dehydrogenase, serum LDH of 0.5 to 1.2. Second option, fluid LDH of 50 units per liter, normal less than 300. Third option, fluid protein to serum protein ratio of 0.6 to 1.4. Fourth option, fluid protein of 10 grams per liter, normal less than 25. And fifth option, a gram stain is needed to order to evaluate this question. Yes, please remember your materials about pathophysiology and try according to topic of our today's lecture, please try to answer all this question. Plan of our today's lecture. We're going to discuss such syndromes like dry and exudative pleuritis, the pleural effusion, the lung compression syndrome, obstructive sleep apnea, acute respiratory distress syndrome, and respiratory failure. First syndrome, it is dry and exudative pleuritis. Let's give definition to this syndrome. Pleuritis or pleurisy, it is inflammation of the pleura that surround the lungs and line the chest cavity and can result in a sharp chest pain with breathing, shortness of breath, cough, fever, or weight loss depending on underlying cause. Ordinary distinguish the dry form, dry pleurisy, and wet form, exudative pleuritis of pleuritis. The wet form of pleuritis is accompanied by pleural effusion. The dry of pleuritis often precedes exudative of pleuritis, pleural effusion. Let's make accent on causes. The most common cause, it is viral infection. Pleura mostly affected by viral infection. Other causes include pneumonia, pulmonary embolism, autoimmune disorders, lung cancer following heart surgery, pancreatitis, chest trauma, and asbestosis. Occasionally, the cause remains unknown. Symptoms and signs of dry and exudative pleuritis or pleural effusion. The defining symptom of pleuritis is sudden, sharp, stabbing, burning, or dull pain in the right or in the left side, depending on affected pleura. Patient usually feel this chest pain during breathing it depending on breathing cycles, especially when one inhales and exhales. Pain feels worse with deep breathing, coughing, sneezing, or laughing. The pain may stay in one place or it may spread to shoulder or back. Sometimes pain becomes a fairly constant dull edge. Depending on its cause, pleuritic chest pain may be accompanied by other symptoms like dry cough, fever and chills, rapid shallow breathing, shortness of breath, tachycardia, sore throat, followed by pain and swelling in the joints. Diagnosis: history taking into account the patient's symptom. We always should do auscultation and percussion of lungs for such patients. What symptoms can we find? When dry pleuritis, physician may hear noises, pleural friction characteristics. On chest X-ray, we can find pleural effusion if it's exudative pleuritis. In laboratory findings, mostly it is inflammatory parameters. Yes, according to kind of inflammation, we told that it is mostly viral inflammation. That's why it will be characteristic mostly due to viral type of inflammation. It will be increased white blood cells, blood sedimentation rate, C-reactive protein, and they are generally, we told about that increase during inflammation. We should identify of pathogen. In case of autoimmune disease, antibodies can be measured, puncture of pleural effusion, and microscopic and chemical analysis of the liquid. Pleural effusion is excess fluid that accumulates in the pleural cavity. The fluid fills space that surrounds the lungs. The fluid excess can impair breathing by limiting the expansion of lungs more than 500 milliliters. Various kinds of pleural effusion depending on the nature of the fluid and then caused its entry into the pleural space and hydrothorax. Serous fluid. Hemothorax, it is blood in the pleural cavity. Moreover, it can be urinothorax, urine. Helothorax, it is hyle or pyothorax. When it is pus, can be found in pleural cavity. Exudative and transudative. Yes, from pathophysiology you remember the difference between these two types of liquid. Transudate mostly specific for congestive heart failure. It is the most often cause of transudate in pleural cavity of transudative pleural effusion. It can be not just due to congestive heart failure. More causes include liver cirrhosis, hyperproteinemia, nephrotic syndrome, acute atelectasis, myxedema, peritoneal dialysis, obstructive uropathy, and end-stage kidney disease. On this picture, you see the ovoid or lenticular opacity in the right upper lung zone is the intralobal effusion collected in the minor fissure. Such effusions are sometimes mistaken for tumors of the lung parenchyma. Intralobular effusions result with treatment of the heart failure. Hence, they are sometimes called vanishing tumors or pseudotumors. You see such on this picture how an interesting can be X-ray picture and how interesting can be transudate. Exudative cause, yes, mostly it is inflammatory cause. Most often they are provoked by pneumonia, by cancer, by pulmonary embolism, kidney disease, or other inflammatory disease. And here you see another X-ray picture with left lower lobe consolidation representing pneumonia. The meniscus in the left costophrenic angle indicating a parapneumonic left pleural effusion. Other and less common causes of pleural effusion. Yes, a less common but not a very rare. Yes, it can be tuberculosis due to pleural effusion due to tuberculosis. It can be autoimmune disease, bleeding due to chest trauma, helothorax due to trauma too, rare chest and abdominal infections, asbestosis pleural effusion due to exposure of asbestos. It can be Majus syndrome due to a benign ovarian tumor and ovarian hyperstimulation syndrome. Here you see a massive hydrothorax of right lung. Symptoms of pleural effusion. Yes, if in general for pleuritis we told that it is pain, and it was more typical for inflammatory pleuritis and for dry pleuritis. For pleural effusion, it will be a little bit other clinical picture. Pleural effusions often can cause any symptoms, and patient is asymptomatic at all. Symptoms are more likely when pleural effusion is moderate or large-sized, or if inflammation is present. Symptoms of pleural effusions may include shortness of breath, chest pain, especially on breathing in deeply due to pleurisy or pleuritic pain, with fever or cough. And you see on this slide another picture. It is mechanism of drain of fluid in lungs after heart surgery. Is the mechanism the same for another causes? Yes, it is general practice of drainage. More information about technique of this manipulation you will learn on surgery. Diagnosis of pleural effusion. Pleural effusion is usually diagnosed on basis of medical history and physical exam and confirmed by chest X-ray. Above the effusion, where the lungs are compressed, they may be bronchial breathing and agophony. The large effusion, they may be cause tracheal deviation away from the effusion. Once accumulated fluid in more than 300 milliliters, there are usually detectable clinical signs in the patient, such as decreased movement of chest on the affected side, stony dullness to percussion over the fluid, diminished breath sounds on the affected sides, decreased vocal resonance and fremitus through this inconsistent and unreliable sign, and pleural friction rub. Commonly used test, additional test for pleural effusion. Yes, most usual it is chest X-ray. It is the simplest and a very informative test, especially for screening for like a first prescribed test. To detailize something, we usually prescribe computer tomography scan of the chest. It can be used ultrasound of the chest, thoracocentesis, yes, to remove fluid and to analyze structure of this fluid. And pleural fluid analysis, what I told, an examination of the fluid removed from the pleural space. Thoracocentesis, one more time, and one more picture. It is when pleural fluid is drawn out of the pleural space in process called thoracocentesis. And it should be done in almost all patients who have pleural fluid that is more than 10 millimeter in thickness, more than centimeter fluid on X-ray or on CT. It is indication for thoracocentesis, not just for removing fluid and for analysis of fluid contains. In thoracocentesis, a needle is inserted through the back of the chest wall in the 6, 7 or 8 intracostal space on the mid-axillary line into the pleural space. Pleural fluid investigation. Pleural fluid red cells counts are elevated in cases of bloody effusions, especially after heart surgery or hemothorax, for example, due to trauma. Pleural fluid amylase is elevated in cases of esophageal rupture, pancreatic pleural effusion, or cancer. Glucose is decreased with cancer, bacterial infections, or rheumatoid pleuritis. Pleural fluid pH is low in empyema, less than 7.2, and may be low in cancer. If cancer is suspected, the pleural fluid is set by cytology. If cytology is negative for malignant cells, either a thoracoscopy or needle biopsy of the pleura may be performed. The fluid is also set for gram staining and culture, and if suspicious for tuberculosis, examination for TB markers. It is adenosine deaminase more than 45, interferon gamma more than 140 picograms per milliliter, or positive polymerase chain reaction for tuberculous DNA. It is tests for TB markers. Once pleural effusion identified as exudative, additional evaluation is needed to determine the cause of the exit fluid. The pleural fluid is sampled for amylase, glucose, pH, and cell count, what we told in previous slide. And here it is a table with comparison of exudate and transudate. Yes, hope you know all about it. You learn it on pathophysiology. Let's make main points one more time here. Okay, main causes for transudate, it is increased hydrostatic pressure, decreased colloid-osmotic pressure. Yes, it usually non-inflammatory fluid. And exudate, it is inflammatory fluid. Inflammation increase vascular permeability. Appearance of fluid for transudate, it usually clear. For exudate, it usually cloudy. For specific gravity, it is normal, it is less than 1.012, and for exudate, it usually with higher gravity, 1.020. For protein content, for transudate is specific less than 2.5 grams per deciliter, and in exudate it more than 2.9 grams per deciliter. For relation of fluid protein, serum protein, it usually less than 0.2 for transudate and more than half for exudate. Difference of albumin contact with blood albumin. For transudate, it usually higher difference with more than 1.2 grams per deciliter, and for exudate, it usually lower. Fluid LDH upper limit for serum less than 0.6, and for exudate it more than 0.6. And one more additional characteristic, it is cholesterol contact. For transudate it's typically less than 45 milligrams per deciliter, and for exudate more than 45. And one more USMLE test for you. A 54-year-old female presents to the emergency department complaining of shortness of breath. She does not speak English and her medical history is unknown. Her temperature is 100 by Fahrenheit, by Celsius it's 37.8. Blood pressure is 130 by 85, pulse is 105 per minute, and respirations are 24 per minute. Physical examination reveals bilateral rales and dullness to percussion and the lungs basis that it was on the left. Hepatosplenomegaly is noted. A chest radiograph is shown on the figure. It's no figure here. Thoracocentesis and hematologic analysis are performed with the following result. Pleural lactate dehydrogenase 54, serum lactate dehydrogenase 92, proteins in serum total 7.0, proteins in pleural fluid 3.8. Remember previous picture. Which of the following conditions are most strongly associated with these findings? Yes, all information in previous table. Options: first, pulmonary embolism; second, cirrhosis; third, nephrotic syndrome; fourth, protein losing enteropathy; fifth, congestive heart failure. Next syndrome for today, we name it lung compression syndrome or atelectasis. Please remember this word. It means compression of the lung. Let's give definition. Atelectasis is defined as a collapse of part of or all of the lungs. When this occurs for whatever reason, fresh air does not reach the thinnest of airways and oxygen and carbon dioxide can't be exchanged. This in turn can lead to decreased level of oxygen being delivered in the organisms and tissues of the body. We name it hypoxia. Atelectasis by types can be acute, occurring suddenly over the matters of minutes, or chronic, developing over the period of days to weeks. Atelectasis may be the result of blocked airway or obstructive, or of pressure from outside the lung, non-obstructive. Almost everyone who has surgery has some atelectasis from anesthesia. Atelectasis is particularly prominent after heart bypass surgery. Mechanisms of atelectasis. First, it is obstruction, blockage of an airway either from inside by foreign body that is aspirated or the mucus plug, or the outside, for example by lung cancer pressing on the airway. Second, compression. Compression of the airways in the lung can be caused by fluid or air surrounding the lungs, as in the pleural effusion or pneumothorax, by the enlargement of an aneurysm of the heart, by tumors such as cancer metastatic to the lungs, lymphomas, or enlarged lymph nodes, or by abnormal distension which causes pressure of the lungs. Third type, it is adhesion. When the surfactant is lacking, the lungs lose surface tension and can collapse. This is the cause of respiratory distress in newborns and can also occur in adults with the adult respiratory distress syndrome. Smoke inhalation and kidney failure. Hypoventilation. Fourth type. Failure to take deep breaths can result in collapse of part of the lung during surgery, especially with general anesthesia, and when breathing is shallow due to pain, such as with rib fractures. Main causes of obstructive atelectasis. Mucus plug after accumulation of mucus in airways, often occurring during the after surgery in children, people with cystic fibrosis, and during severe asthma attack. Foreign body is common in children who have inhaled the object, such as peanut or small toy part, into their lungs. Here you see picture, it is chest X-ray with lower lobe atelectasis. Narrowing of major airways from disease, like chronic infections including fungal infection, tuberculosis, and other diseases. It can be tumor in major airway. It can be blood clot after significant bleeding into the lung that can't be coughed out. For non-obstructive atelectasis, let's discuss main causes. It can be injury like a chest trauma. It can be pleural effusion, it can be pneumonia, it can be pneumothorax, scarring of lung tissue, or tumor. And you see here, yes, first picture, it is hydrothorax that press left lung and lead to atelectasis. Second picture to the right, upper right, it is pneumothorax with compression of right lung, and by the arrow you see a pleural white line that pressed upper. And last picture, it is pneumothorax with atelectasis too. Clinical symptoms of atelectasis. Atelectasis may have few or no symptoms if it develops slowly or involves only a small portion of the lungs. Conversely, if the condition affects a large portion of the lungs or develops rapidly, symptoms may be dramatic and may even progress to shock. Common symptoms include shortness of breath, It is the most common symptom. It is coughing, often described as hacking, and is most often non-productive, meaning that no mucus is coughed up. It is pleurisy, chest pain that is sharp and worsens with a deep breath or coughing. Pleuritic chest pain may occur. It can be fever. At one time, it was through the fever was a sign. For diagnosis of atelectasis, we use physical examination. Findings may include quiet or absent breath sounds. It is chest X-ray. The trachea and heart may be deviated towards the side of the chest where the lung is partially collapsed. The diaphragm may also be elevated on the side of the collapse. Chest CT scan may further define an area of possible atelectasis and to look for other causes of obstruction, such as tumor or enlarged lymph nodes. Bronchoscopy may be used to determine the cause of a bronchial obstruction. Blood gases or oximetry may be done to determine how much atelectasis is interfering with the ability to get oxygen to your tissues. Other tests may be ordered depending upon the condition. For example, a blood work to evaluate kidney function. Here is the example of bronchoscopy, and here you see a peanut in the left main bronchus of child. And one more USMLE test for you today. A 37-year-old male is brought to the emergency department following a motor vehicle accident. On arrival, respirations are shallow. Blood pressure is 80 by 60 mm Hg. Pulse is 122. A respiratory rate is 29. Physical examination demonstrates absence of breath sounds on the patient's left side. Chest radiograph is shown on the figure. You see this figure here. Which of the following is the most appropriate next step in the management? First option, it is echocardiography. Second, needle thoracostomy or the left second intercostal space. Third, chest tube placement in the left fourth intercostal space. Fourth option, transfusion of packed red blood cells. And fifth, in endotracheal intubation. Next syndrome for today, it is obstructive sleep apnea. Let's discuss definition and causes. Obstructive sleep apnea is caused by obstruction of upper airway. It is characterized by repetitive pauses, apneas in breathing during sleep, which typically last for 20 to 40 seconds despite the effort to breathe. Obstructive sleep apnea is usually associated with a reduction in blood oxygen saturation. Obstructive sleep apnea is commonly accompanied with snoring. The main causes of OSA are old age, temporary or permanent brain injury, decreased muscle tone, excess soft tissue around the airways, common with obese patients, yes, very typical for obese patients. Sometimes physical in the throat or mouth jaw shape. Symptoms of obstructive sleep apnea. It is excessive daytime sleepiness. It is loud snoring. Episodes of breathing cessation in sleep. Abrupt awakenings by shortness of breath. Awakening with a dry mouth or sore throat. It is awakened with chest pain, morning headaches, difficulty concentrating during the day, experiencing mood changes, difficulty staying asleep, and high blood pressure. For diagnosis of obstructive sleep apnea, we can use such method like that we named nocturnal polysomnography. It records brain wave changes, eye movements, leg movements, blood oxygen levels, muscle tone, heart rhythms, and respiration during sleep. Moreover, we can use oximetry and Epworth Sleepiness Scale to measure the patient's level of daytime sleepiness. And it can be 3 ratings of obstructive sleep apnea. Mild, it is 5-14 episodes of apnea or hypopnea per hour. Moderate, from 15 to 30 episodes of apnea or hypopnea per hour. And severe, over 30 episodes of apnea or hypopnea per hour. A 30-second epoch of polysomnographic recording in the 13 channels, muscular tension, eye movements, bioelectrical brain function, heart rate by ECG, breathing, snoring, body position, oxygen saturation are recorded. During the first 10 seconds, an obstructive sleep apnea cessation of breathing is clearly visible as a flat line in the flow channel. Yes, you see on this picture that it was breathing sounds, and in first part of this recording it is a flow channel. It means that it was a period without breathing at all. It was episode of apnea. And here is the scale, Epworth sleepiness scale question to determine daily sleepiness. Yes, we give usually to the patient. It contains from different situations like sitting, reading, watching TV, sitting inactive in public place, as a passenger in the car, and other situations. And by a scale from 0, that is would never fall asleep, to 3 with high chance of fall asleep, patient should answer to the question. And according to filling this table, we check general points according to this scale. And next USMLE step for you. 33-year-old man presents to physician complaining of excessive daytime sleepiness. This problem has worsened slowly over the past few years, but is now interfering with his ability to play with his grandchildren. He worked previously as an overnight train conductor, but he has been retired for the past 3 years. His wife knows that he often snores loudly during sleep. He has also been experiencing headaches in the morning and endorses a depressed mood. His physical exam is most notable for his large body habitus, BMI of 34. What is the best description of the underlying mechanism for this patient's excessive daytime sleepiness? First, insufficient sleep duration. Second, circadian rhythm sleep-wake disorder. Third, poor oropharyngeal tone. Fourth, deficiency of the neuropeptides orexin A and orexin B, and psychiatric disorder. Please choose correct answer according to your opinion. Next syndrome, acute respiratory distress syndrome. I told a little bit about this syndrome today. It's more usual for children, especially for newborns. But it can be found in an adult person. Let's give definition. Acute respiratory distress syndrome or respiratory distress syndrome or acute lung injury, adult respiratory distress syndrome or shock lung. It is a severe, life-threatening medical condition characterized by widespread inflammation in the lungs. Common causes of ARDS include sepsis, pneumonia, trauma, multiple blood transfusions, babesiosis, lung contusion, aspiration of stomach contents, and drug abuse or overdose. Other causes of acute respiratory distress syndrome include burns, pancreatitis, near drawing in the inhalation of chemical irritants such as smoke, phosgene, or chlorine gas. Some cases of ARDS are linked to large volumes of fluid used during post-trauma resuscitation. The syndrome has a high mortality between 20 and 50%. Mechanisms of ARDS. Acute respiratory distress syndrome is a pathology of the microscopic air sacs in the lungs alveoli that leads to decreased exchange of oxygen and carbon dioxide gas exchange. Acute respiratory distress syndrome is associated with several pathological changes. The release of inflammatory chemicals, breakdown of the cells lining the lungs' blood vessels, surfactant loss leading to increased surface tension in the lung, fluid accumulation in the lung, and excessive fibrous connective tissue formation. Signs and symptoms of acute respiratory distress syndrome. The signs and symptoms usually begin within 7 to 2 hours after the initial insult or injury to the lung, and may include severe shortness of breath, fast breathing, cough, and low oxygen level into the blood. A chest X-ray frequently demonstrates generalized infiltrates or opacities in both lungs, which represent fluid accumulation in the lung. Other signs and symptoms may be associated with the underlying disease process, like low blood pressure and fever. For diagnosis, we usually use Berlin criteria of year 2012 proposed by European Society of Intensive Care Medicine. Yes, you understand that it is emergency care situation, endorsed by the American Thoracic Society and Society of Critical Care Medicine. Yes, what it includes these criteria? It is acute onset. It is bilateral infiltrates on chest radiographs pairing costophrenic angles. It is pulmonary airway pressure less than 18 mm hydrargium obtained by pulmonary artery catheterization, if this information is available. If it is unavailable, then lack of clinical evidence of left atrial hypertension. If a relation between a parcel pressure of oxygen and femurs pressure of oxygen less than 300 mm hydrargium or 40 kilopascals, acute lung injury is considered to be present. If this relation less than 200 mm hydrargium or 26.7 kilopascal, acute respiratory distress syndrome is considered to be present. And next USMLE test today. A 48-year-old female suffers a traumatic brain injury while skiing in a remote area. Upon her arrival to emergency room, she is severely hypoxemic and not responsive to oxygen therapy. She is started on a medical ventilator and 2 days later upon auscultation. You note late inspiratory crackles. Which of the following is most likely normal in this patient? First option, type 1 pneumocytes. Second, type 2 pneumocytes. 3, chest X-ray. 4th, alveolar arterial gradient. 5th, left atrial pressure. And respiratory failure. It is last syndrome for today that I am going to discuss with you. Let's give definition to it. Respiratory failure occurs when the respiratory system fails into oxygenation and or carbon dioxide elimination. Yes, you understand that like a heart failure, respiratory failure it's like a conclusion of all syndrome and respiratory system disorders. It can be like a result of all lung and most of non-lung disease. And all syndromes that we discussed before, all diseases that we discussed before, like a result, can lead to respiratory failure, like generalized failure of our respiration. Respiratory failure may be acute, that develops over minutes to hours, chronic, that develops over several weeks, months, or sometimes even years. Clinical markers include polycythemia and cor pulmonale. Types. It can be hypoxic when parcel pressure of oxygen less than 60 mm hydrargium or 8 kilopascals with a normal or low parcel CO2. Is caused by ventilation perfusion mismatch. And another type, it is hypercapnic. It is the opposite situation when the parcel pressure of oxygen is normal, but pressure of carbon dioxide is more than 50 millimeters hydrorgium or 6.5 kilopascals and indicates inadequate alveolar ventilation. Causes of respiratory failure. For first type, for hypoxic, it is chronic obstructive pulmonary disease, the most often cause of COPD. We discussed this disease a lot in previous lectures. It can be pneumonia, pulmonary edema, pulmonary fibrosis, asthma, pneumothorax, or pulmonary embolism. It's not all, but most often. And type 2 hypercapnic, it is pulmonary hypertension, cyanotic congenital heart disease, bronchiectasis, acute respiratory distress syndrome, kyphoscoliosis, and obesity. For type 2, it is neck injury, it is obesity, we talk about it, it is hypothyroidism. For type 1, more than we talk in previous slide, it can be drug overdose or poisoning, it can be myasthenia gravis, it can be polyneuropathy, poliomyelitis, muscle disorders, and head injuries. A little bit more about causes of respiratory failure. Conditions that affect the nerves and muscles that control breathing. Examples include muscular dystrophy, amyotrophic lateral sclerosis, spinal cord injuries, and stroke. Damage of the tissues and ribs around the lungs. Problems with spine such as scoliosis, of course in very severe cases. Drug or alcohol overdose. An overdose affects the area of brain that controls breathing. Lung diseases and conditions such as all previous, yes, it is COPD, pneumonia, acute respiratory distress syndrome, pulmonary embolism, cystic fibrosis, etc. It is, of course, acute lung injury, inhaling harmful fumes or smoke. Signs and symptoms of respiratory failure. Yes, like a generalization from all previous syndromes. Let's discuss the main of them. It is paroxysmal nocturnal dyspnea, orthopnea, pulmonary edema. It can be cyanosis, confusion, and reduced consciousness, localized pulmonary findings, tachycardia, and cardiac arrhythmias. And here you see a transverse section of the heart from the patient with primary idiopathic pulmonary hypertension. It what we told cor pulmonale with a very hypertrophied right part of heart. So more signs and symptoms. It will be hypoxemia, acidosis, cor pulmonale. Yes, we talk about it most usual for pulmonary hypertension, right ventricular failure, hepatomegaly, and peripheral edema. Diagnostic tests: pulmonary function tests, spirometry, arterial blood gas tests, etc. We usually always do chest X-ray. We always do full blood count. For example, for what? Anemia contributes to hypoxia, yes, for differential diagnosis. It can be polycythemia that contributes to chronic hypoxemic respiratory failure. And we do for such patients renal and liver function tests. May provide clues to the etiology or identify complications associated with respiratory failure. Serum creatine kinase and troponin I to help exclude recent myocardial infarction. We usually do thyroid function test. For example, hypothyroid chronic hypercapnic respiratory failure can be cause of our symptoms. We always do echocardiography to exclude or find any cardiac cause of acute respiratory failure. And we always do ECG to find cardiovascular cause, dysrhythmia resulting from severe hypoxemia or acidosis. Right heart catheterization if there is uncertainty about cardiac function. And pulmonary capillary wedge pressure, distinguishing cardiogenic form of non-cardiogenic from non-cardiogenic edema. And here you see the algorithm of our management according to arterial blood gas test. Yes, according to analytic approach to acid-base disorders. You can analyze it individually or on practical classes with your teacher. And approach to patient with hypoxia. One more algorithm according to parcel pressure of carbon dioxide to determining respiratory failure or some other problems with arterial blood gases. And last test for today. A 50-year-old Caucasian male presents to the emergency department complaining of shortness of breath and unintentional weight loss over the past several months. On physical exam, the patient appears quite thin and breathes through the pursed lips. Breath sounds are decreased in all lung fields. Which of the following findings is expected on spirometry? Remember spirometry from previous lectures. Increased forced expiratory volume in first second. Second, decreased relation between forced expiratory volume first second and forced vital capacity. Third, it is decreased TLC. Fourth, it is normal forced expiratory volume first second but increased forced vital capacity. And fifth one, it is normal lung values. For today, that's all. You can answer individually on this question. For your comments, for your questions, I'm waiting in comments under this video or preferably in our Facebook page. There we always waiting for some discussion and about this lecture too. And as usually, I ask you to write your name and group number in comments under this video for everyone who listening this lecture. For today, that's all. Thank you. See you on the next lecture. Goodbye.